Okay, thank you for being here today. You're a professor of urology at Vanderbilt with an area of expertise in neurourology, female urology, and incontinence. But today, I want to interview you about your other great interest, and that is quality and quality assurance. What is your job at Vanderbilt vis-a-vis quality?
So, Phil, my job at Vanderbilt is actually on several fronts. I'm vice chair of the section of surgical sciences for patient quality and safety. So, in that role, I interface with my surgical colleagues really across all the surgical disciplines related to quality issues as they pertain not only to systems type concerns, but also physician behavioral concerns as well. I also am executive medical director for safety and quality for Vanderbilt University Hospital, so it's more of a hospital administrative position. And then last, I'm medical director for risk management, so we do quite a bit of our litigation prevention and our litigation awareness through that position.
What are the current hot button issues in quality that you're dealing with?
Well, like everything now, we're seeing the evolution of rapidly and massively available data to the general public. So the areas that are really hot buttons, if you will, are what are called the reportable data and the patient safety indicators. And what we're seeing now is by virtue of CMS regulation, Joint Commission of Hospitals recommendations, and even state boards, we're being required to share our experience with a variety of issues related to patient care to the general public. So, for instance, there are a variety of patient safety indicators such as ventilator-associated pneumonias, central line infections. The thing that's most pertinent to urology now is the recent publication and awareness of the patient safety indicator of catheter-associated urinary tract infections. That used to be only reported through intensive care units. Now it's a data that's really reported throughout the hospital setting, both in intensive care and non-intensive care settings. And the importance there is we have learned from prior experience at Vanderbilt that care bundles are really very helpful in terms of reducing untoward experience. Well, we learned with our central line infections, for instance, that having a central line emplacement bundle, which included a daily assessment of need for line after placement, we were able to decrease our central line infections dramatically. Well, we used that experience to now develop a bundle for the management of urinary catheters, Foley catheters, in terms of when to be placed, when to be removed. We as urologists tend to sort of have a very high level of comfort in our care is reflective of that related to Foley catheters, because obviously it's a device that is very common in urologic practice. Our peers amongst the general medical care groups are not as careful, are not as experienced, not as aware of some of the risks with Foley catheters. And so with the evolution of these bundles, what we've been able to do is really give people a framework to govern their use of catheters, the appropriateness of placement initially, and then the appropriateness of and length of retention.
Aside from catheter-associated infections, what aspects of value-based purchasing are likely to have the greatest impact on urologists? 30-day readmission rates? What kinds of things do you think will impact urology?
Well, interestingly enough, there is already a substantial component of value-based purchasing around readmissions for cardiac diseases and pneumonia. One of the things that we will see in the surgical subspecialties in the not too distant future is some negative attribution in terms of reimbursement with surgical readmissions. And so one of the things that, again, we're focusing on at Vanderbilt, but I think many institutions are doing around the surgical sciences, is looking at the specific transitions of care of patient from outpatient to inpatient back to outpatient, and how to facilitate those transitions, not only from the standpoint of making sure that things are done in an appropriate time or discontinued at an appropriate time, but appropriate preparations are made for discharge and then outpatient care. Because again, we're now getting rid of the sort of concepts of episodes of care, and we're looking at the entire continuum much more so now than ever. The ability to correctly predict that and control that continuum is going to have either very positive or very negative financial attributions to institutions around the whole transition of care issue.
specific metrics are you looking for in the future with regard to Medicare reimbursement going ahead?
So CMS has been very aggressive about using candidate measures and looking at measures around care. And again, when we talk about measures, we're talking about sort of threshold of good care and what measures look like. So again, there are measures such as catheter-associated urinary tract infection is the one that most urologists are used to or comfortable with. But another one that we tend not to think about, for instance, is surgical site infection. Maybe not such a big issue for urology, much bigger for some of our colorectal and other subspecialty colleagues. But I will tell you that that's going to be an area of great focus in an area where the CMS has already sort of established a broad architecture for review. And as we move forward, what will happen is that architecture will then be migrated from top down and start getting to smaller specialties such as urology.
Many departmental chairs are trying to implement specific protocols to maximize quality outcomes. Have you seen urology chairs trying to standardize procedures, practices, and protocols? And how receptive are physicians to that effort to change their practice? Have you had problems?
You know, Phil, that's a great question because so much of care and quality of care is a direct result of physician behavior. And I'm not talking about yelling, screaming behavior. I'm just talking about the willingness of physicians to use evidence-based medicine as a way to create algorithms for appropriate care. So much of this effort actually is coming from outside strict departmental structures and actually coming from institutions. So I would say that from our standpoint at Vanderbilt, one of an experience that we've just had recently with this whole concept of standardizing care is around the whole administration of antibiotics for prostate biopsy and getting physicians to agree on really what is evidence-based in terms of use of antibiotics, appropriate preparation of the rectum, and there's tremendous, for instance, argument about whether or not a routine enema should be done around before a prostate biopsy. So just those sort of standardizations have been very difficult because in reality, much of what drives physician practice is experiential behavior from the past. And so it's like old dogs, new tricks, training people to acquire and utilize new algorithms is very difficult. And however, as with all things in life, what some institutions are doing already is creating reimbursement structures that are reflective of adoption and facilitation of protocols or the lack thereof.
Are you doing those perianal swabs at Vanderbilt prior to prostate biopsy?
We are not, certainly I'm familiar with that. I'll be honest with you, the thing we have struggled with the most at Vanderbilt is whether or not routine cleansing of the lower bowel should be done prior to biopsy. I personally feel, based upon my colorectal experience and their problems with surgical site infection, that bowel preparation is a critical part of prevention of urinary tract infection and sepsis after prostate biopsy.
What therapeutic areas are most important to you from a quality perspective, and how do you see this changing in the next 3 to 5 years as we move on?
Well, clearly my focus obviously is the interaction of the surgical specialties, including urology, and the larger organism of the entire hospital. So the focus is driven both by the demands and needs of CMS in terms of our reporting structure. So a lot of what I do is really, I would hate to say this, but it's almost retroactive in terms of responding to requirements. We are becoming more proactive in terms of developing, again, standards or algorithms of care. We're also becoming very proactive in some of our medical risk management as well in terms of dealing with the physician behavioral aspects around that. So those areas of focus within surgery have become very, very important for us, mainly as essentially being good citizens to the larger hospital environment.
Has the push to decrease length of stay impacted quality?
A lot of argument about that, and it's interesting you mentioned that. Vanderbilt has always, my institution has always done very well with length of stay, and so we are very comfortable with this concept. The issue with length of stay is preparation for outpatient care and management, and again, that transition is critical. So we're all being forced to really very assiduously evaluate our length of stays and decrease them as much as possible as part of the general cost modification, cost reduction strategies that are being utilized by all. But the corollary to length of stay is appropriate transition to the outpatient environment, such that you have an informed patient who's capable of self-care, with or without family members who are also capable of that, who has realistic expectations and understanding of what is within the realm of normal of the postoperative convalescence, and also when they should react in a more aggressive way in terms of returning for care should there be a decrement in patient status.
Now, you're always trying to balance cost savings with quality improvement, and it can be extremely difficult. What about the amount of time per office visit? Is there anyone looking at that and how physicians are being pushed to see more and more patients in more and more contracted periods of time?
Yeah, Phil, this is a fascinating area where, if you will, the drive to increase volume really has some very negative impacts. And obviously one of the things that we're focusing on is patient satisfaction as a direct attribute to decreasing length of visit. And what's clear is if you look at complaint cycles across physicians, one area that has become much more prominent than before is this he was rushed or she didn't take enough time to listen to me, which are all aspects of the pressures of, again, trying to push through volume in order to maintain stability of revenue. And we have attempted to deal with this by utilizing higher involvement of mid-level practitioners. So patients are made aware that they may or may not see the physician, obviously at a certain scheduled appointment. They are also made aware that for continuation of care, there may be a mid-level who makes significant decisions with the approval of the consulting physician related to care. The other thing that we're really trying to do to help with that decrement of time is to create standardized educational materials regarding common procedures, common treatment cycles that can be given to the patient in print or web-based for that matter as well, such that they have resources that they can go to make up for some of the decrement that we're seeing and the ability, frankly, the ability to spend time and to answer all questions appropriately.
What type of project management support do you have? Is quality led mostly by physicians and nurses or by non-clinicians trained in process improvement? Go ahead.
I'm sorry. At our institution, the process is largely led by a dyadic role of physician and nurse. We do have quality consultants, but all of our quality consultants are actually experienced nurses who've received extra training in quality roles. We also have a very interesting group at our Center for Surgical Safety where we actually have process engineers who are PhDs who help us with some of the systems-based analysis. But the actual, if you will, directing and strategic formation comes from a dyadic relationship between physician and nurse. Nurse is representative of basically the operational side of the hospital.
Do you use Press Ganey at Vanderbilt?
Well, we do use Press Ganey. We also have several homegrown tools, and we're actually looking, because of perhaps the lack of specificity of Press Ganey, and for that matter HCAPS as well, we have migrated to some tools that we've developed with our educational school, looking at specific items and really sort of creating a condensed, if you will, symptom score that patients are given specifically about their experience, not only in the hospital, but also about their physician-specific experience, to give us some more greater direction, if you will, in terms of focus about what the areas of improvement are. And we use these not in a retributional way, but actually in a way, and actually a process improvement way. So we look at those scores not only from the standpoint of systems-based improvement, but also from the aspect of physician, nurse, and improvement of care, looking at areas that potentially could be improved upon. And obviously the most common is communication and communication skills.
When I think of Press Ganey, it appears that the satisfaction results are very sticky. And the question is this a result of a non-response bias? Because dissatisfied patients would seem to be most likely the ones to respond to surveys. And surveys done prior to discharge might suffer from the fact that no one wants to offend their caregiver. So there's a whole variety of reasons why these surveys may be problematic. How do you deal with that?
You're exactly right. I mean, we do not do in-hospital surveys because of exactly that concern. We do post-hoc surveys. There is occasionally selection bias. A person who's extremely dissatisfied will want to make sure that everyone understands the dissatisfaction. But there is a flip side to that, and the patients are also extremely satisfied, will also want to provide materials. I think that my take-home message for physicians is increasingly, not only will our institutions require these metrics to be kept and tracked, but actually now third-party payers are keeping and tracking these. And so I can tell you that Blue Cross Blue Shield actually, for its reimbursement contracts, uses these scores as part of their metrics in terms of, if you will, the bonus structure that they put in their hospital-based contractual financial relationships. Will that happen with CMS? Well, obviously CMS has tremendous data through the HCAHPS, but the HCAHPS, again, they are really episodic specific. They're not caregiver specific, and so they're going to be much more difficult to extrapolate because the physician specific questions on the HCAHPS are very limited, and again, really are not specific to either the primary physician or any of the consultants.
So we have to learn to live with these. They're not going away.
No, they're not going away, unfortunately. As a matter of fact, I think they'll become a bigger part of what we deal with. Another aspect is that I'd just like to interject, the Joint Commission has established goals for hospital credentialing groups around this concept of professional evaluation. So they've got ongoing professional evaluation and focused professional evaluation metrics that they require, and we are actually using these scores as part of that evaluation schema in direct response to what Joint Commission is asking for. Now, the Joint Commission hasn't specifically said they want patient satisfaction in those ongoing annual assessments, but we feel it is coming, so we are already building those into, if you will, the 360 assessment that every physician has to undergo every year now.